I'm going to introduce Professor Geoff Isbister, and Geoff works as a clinical toxicologist with the New South Wales Poison Centre, but you've probably come across his work if you've worked in Australia in emergency or critical care in some form or another. So Geoff was involved with the RAVE2 study on redback antivenom. He's worked heavily on first aid for blue bottle stings, Australian SnakeBite project, and the use of antivenom and how we dose and administer it, as well as lots of work debunking the myth of whitetail spider and skin ulceration, work with scorpion envenomation, and he's awarded the Member of the Order of Australia in 2019 for his contributions to toxicology in Australia. I'm going to let Geoff come down and speak. Please feel free to ask him questions about this interesting topic.
Thanks for that introduction. So I probably should say is I was trained as an emergency physician. Don't do much emergency medicine anymore. I mainly practice in clinical toxicology at the Mater in Newcastle. It used to be the largest tox unit in Australia, except PA started in Brisbane and it's now bigger. And I work for New South Wales Poison Centre. Do I just press the arrows on this? Yeah, perfect. Okay, so I've given this talk in Newcastle a number of times over the last 20 years, and it's exactly the same talk. I worked in Darwin as a registrar, so the only retrieval I ever did was fixed wing retrieval in the Northern Territory when it used to be the Northern Territory Aeromedical Retrieval Service, and a lot of that was spent bringing patients with snake bites back to Darwin Hospital. This actually happened. Many of you may not have heard this because this happened a year or two before I went to Darwin, and I was in Darwin in the end of the 90s. He didn't actually get a Darwin Award because, as you know, you have to die to get a Darwin Award. So this guy was on I should go back to the picture. So if anyone hasn't been to Darwin, it's got this huge harbour, and it's a very, very long way around it, but it's quite easy to get the ferry across from Darwin to Mandorah. So this guy got bitten down where that arrow is by a mulga snake. He was asked why he got bitten on his left hand, and he said, well, he couldn't put his beer down, which was in his right hand, while he was trying to pick the snake up. He got bitten several times while he was trying to do that, then hopped in the car with a friend. They then drove to Mandorah pub there, as you can see, right up to there, went into the pub. I think they might have had it in the bag. He pulled the snake out and showed it to everyone, and I think got bitten several more times. He then became quite unwell. So I'll talk about, so mulgas make you the most unwell of all snakes in terms of just vomiting and abdominal pain compared to, say, brown snake, where you get almost no symptoms. So they eventually just left him outside and called 000 to get him across. So I don't know how it's done now, but back then, the retrieval from Mandorah pub back to Darwin required an ambulance on the ferry across the harbour. So they picked this guy up and then took him up to Darwin there. At that point, he tried to sue the hospital. He lost his arm because it has got an necrotic venom. Tried to sue the hospital for that, but essentially that was a life-saving treatment. So, benefit versus risk. And I'm going to talk about, as I said, helicopters and antivenom. This was my what should I cover, and I'll try and cover most of that. A recent retrieval in Darwin, talking about pressure bandaging, what the Australian snakebite studies has shown in the last 20 years and what new things there are. But I want to also talk about, you've got helicopter versus fixed wing there. I'm going to talk a lot about helicopter versus road ambulance because in most of these cases, the mistake's been the helicopter, and we've had a fantastic one in Newcastle. I think it was the shortest helicopter retrieval ever. So this is the hunter retrieval story. This is the first case. This is in 2000. I was the registrar there. This was a 6-year-old who had a witness bite by a brown-coloured snake. He was located at a rural property 9 minutes drive from Cessnock Hospital. He appeared unwell and had vomited, and he was then, well, it was 10 minutes drive to Cessnock Hospital and 40 minutes by helicopter to Newcastle, which is only one way. So there was a primary helicopter retrieval from the location of the John Hunter Hospital. In the emergency department, he was asymptomatic. We only ever heard about this patient once. He was at John Hunter, so this was 2.5 hours after it all happened. They consulted toxicology, bloods collected, no evidence of envenoming. And my point here is that you, if you were going to collapse from a brown snake bite and have a cardiac arrest, probably would have been about the time just after you'd taken off to bring him back to the John Hunter Hospital. Yet he could have been at Cessnock Hospital in about 10 minutes, where there's antivenom. So the one thing about snakebite is there's antivenom in every single hospital in New South Wales. There's actually, the limiting factor isn't antivenom, it's what the laboratory at the hospital can do. Or there's not a doctor, although we now have more nurse practitioners who can easily, all you've got to be able to do is treat anaphylaxis, so it's not hard. Hence the neurosurgery. As we know, you want to take the patient to the neurosurgeon, but in this case, it's the opposite. So the next one, so bring the patient to definitive care. It's not a neurosurgical unit in the case of snakebite, it's to antivenom. And to be honest, we manage snakebite better in rural centres, because the other thing we get in larger base hospitals is the belief in expert care of snakebite there that's 20 years old. And so they don't call the poison centre, they don't get the most current advice. Whereas if I get a GP, VMO, or someone who's actually doing a locum in a small hospital in Queensland, I tell them what to do, this is what you need to do, that's what happens. And they don't necessarily need to come to a larger hospital. So the next case, I can't remember this one well, I only have it here because it's from the last talk I gave to the Hunter Retrieval Service. This is a case where you're called to retrieve a brown snake in a remote hospital in the Upper Hunter. The Hunter's an interesting region because there's lots of hospitals and they're reasonably close together. It's not completely remote, but you actually have different problems because of the hospitals being at least half hour, an hour apart. So they've got point of care INR, point of care D-dimer, both normal in this patient. The patient has nausea, headache, abdominal pain. The hospital obviously has antivenom, but they have no SVDK. So anyone want to say what they would do here? No takers? No one game. Okay, well, I won't answer it. By the end of it, hopefully you'll know what the correct answer is there. The one thing, the point to make here is point of care INR and point of care D-dimer do not work in snakebite, and it's to do with the venom. It's specific to that. They're designed for warfarin, essentially, or for anticoagulation, and they don't. And a study was done in Queensland where basically we showed that it missed a whole lot of cases where there was severe coagulopathy. So next case, we've now advanced right through to 2016. This was a 48-year-old who was bitten. I always said, we hardly ever get any death adder bites, but yeah. So this is a guy who was bitten about 2 o'clock by what he said was a blue tongue. His neighbour was a snake handler and said it was a death adder. And even if it hadn't been identified, if someone says it looks like a blue tongue lizard and it's a snake, it's almost always going to be a death adder. The bite was in Muswellbrook. There's primary retrieval with medical retrieval at 2:30. They were at site at 3:25. This is from the ambulance sheet. And the patient had headache, nausea, abdominal pain. And it's that point they called the toxicology service, which I said need to give antivenom. And they said, we haven't got any. And I said, so why did you fly all the way there with a doctor without antivenom? And then I said, well, you actually need to take the transport 15 minutes down, but the patient 15 minutes down the road to Scone Hospital. So however they did it, they put this patient on a truck or something and took them to Scone Hospital. They gave them antivenom basically in the back of the ambulance and then flew them back to Newcastle. So we advanced a bit further here. We got the call this time in the middle of the retrieval, but not early enough to actually change what happened. So they were given antivenom at 4 o'clock. So that was at 2 hours post-bite, which is pretty good. But it was only because this patient was right near Scone Hospital. We keep polyvalent at the Mater in Newcastle, at the John Hunter in Newcastle. I thought the retrieval service had it. I was told at this case, oh yeah, they have it, but it's kept in a fridge at the John Hunter Hospital, not on site. And then there's one kept in Scone Hospital for the simple reason it's halfway between Tamworth and Newcastle. So that if we want to get it, this patient was just lucky enough to be near there. So they had mild envenoming. Really, that the white cell counts up indicates that they were envenomed, and they were probably given it early enough to prevent more significant neurotoxicity. So this is a nice picture of a death adder. So the next case came 4 years later. In between those times, the head of the Sam Vidler, who's the director of Retrieval in Newcastle, was a previous toxicology registrar for 6 months, which has made things much easier since then. We had significant discussion, and they now keep antivenom at the base for this in the future, so rather than the John Hunter Hospital. So this is a 52-year-old male who was hiking at Seal Rocks, trod on a snake, took a photo of the snake. He walked 20 minutes simply to get phone reception. And then again, there was a primary retrieval with a doctor. So that's the picture. This is one thing about death adders, and this is why people tread on them. That even if you get a close look at that, it takes a long time to find that snake. That's the blown up bit of the snake there. So for those who don't know, Seal Rocks is up the top there. Newcastle's there. It's not that far, but by helicopter. So we got the call, possible death adder bite. They couldn't find the antivenom in the fridge, and that was just a simple mistake. It was actually in the fridge. It was behind something else. So they actually went past John Hunter and collected the antivenom, and to be honest, they said, it took all 5 minutes because it was all prepared, so it didn't really, besides having to land a helicopter and take off again. And they got to the patient at 1 o'clock. The only error in this case is they didn't call us at the time, and the next time we heard about the patient is after they arrived at John Hunter, unwell, had ptosis, ophthalmoplegia, so they clearly had neurotoxicity, and that's the picture of the ptosis that the patient had. I was called from John Hunter and they got polyvalent, but unfortunately because of that flight back, it was delayed, so it could have been given in time. So we're getting better. It's taken 20 years. But my point is that if we can get retrieval calling toxicology straight away and knowing where antivenom is, we can give it very quickly. So this guy had quite significant envenoming. It's hard, based on the time of the antivenom, it's hard to know whether the first case was as severe or less severe because they got antivenom a lot earlier, and I'm going to talk about that as I go. And this is the guy in the next morning. Ptosis is resolved. He'd otherwise improved, and he got antivenom at 3 hours and 20 minutes. So the other thing I want to talk about is, I don't know whether it happens here, but I was told in Newcastle, their old base, is that one of the helicopters for whatever it was, NBN News or something, was always close. So they always saw Westpac take off. And so we would always get I would always get a call from the media before I got a call about the snake bite. You might have heard, did anyone, this was only like about a month ago, woman bitten in the bed by a large eastern brown snake. It's not actually ever been corrected on the media because they didn't contact anyone. And that was a retrieval back to Toowoomba Hospital. And I was actually on holidays, and I saw this, and I said, I reckon that's a mulga bite. The only snake that bites people in beds is mulga, because they bite toes and fingers that move in bed. It definitely won't be a brown snake. And I said, and I sat there. 10 minutes later, I got I actually didn't get a call. I just got an email from Nick Buckley, who was on call for the Poison Centre. And this is the actual Poison Centre record. This is what he had in that. And luckily, yes, Nick got the same story, but they'd had some of these bloods back. Unfortunately, they had bloods back, which meant, again, the other thing with hospitals is we want to get called to the Poison Centre as soon as possible, because here we've waited for blood tests, and I'm going to talk about that. But for those who don't know, so severe mulga is a black snake. So yes, it's a big brown snake. It's just not a big brown snake. It's a big black snake that's brown coloured. It doesn't cause VIC it doesn't cause a consumptive coagulopathy. It causes an anticoagulant coagulopathy, and it causes myotoxicity. And so what you'll get is a prolonged APTT, a normal D-dimer, a normal fibrinogen. You may get an abnormal INR. So this is more like just someone having heparin or warfarin. It's an anticoagulant coagulopathy. This patient's CK is already up, and this antivenom was given just after 6 hours. As I said, I suspect it's going to go into the hundreds of thousands. Luckily, the patient, it only went into about 20,000. But if the hospital had called, at least we would have got it in probably an extra 2 hours. And I mean, we weren't involved in terms of the retrieval. So that's the big brown snake. So in Australia, for some silly reason, we named the snakes all wrong. So lots of brown snakes aren't actually brown, or they're striped, and you think they're tiger snakes, but tiger snakes are tiger snakes because they're striped. Or black snakes, the most important black snake is there. It's a mulga. It's brown. The next, the colettes is not brown. The only ones really is a red-bellied black snake. Yes, it's probably the most common in terms of snake that meets human, simply because it's on the East Coast and there's more humans on the East Coast. But yeah, it's black snake. So no one ever gets bitten by a brown snake. They get bitten by a brown coloured snake, and no one can tell the difference. I can't really tell the difference until I got a PhD student who was a snake handler, and now he just identifies all the pictures for me. So if you've got, and in the Poison Centre, we can now do that. So we can get good identifications from pictures if the picture's taken properly. Particularly if it's a dead snake, you can easily get a proper picture taken so that it can be quickly identified. And that makes a difference. This is the most recent one. This was the one in Sydney only about 2 weeks ago. So I was at work. So Channel 7 wanted to do an interview, was the first thing we heard about this. I hadn't heard any more than that. The Children's Hospital spent the whole afternoon putting together a media release for this. And I just happened to be on call for the Poison Centre that day, and then finally got called about the patient about 5 hours after we'd done all the media release for it. And it just proved as I said, I'd already said to the Children's Hospital, I said, a helicopter got this patient, I guarantee they're not envenomed. And sure enough, they're not envenomed, they were fine. And it's not so much the helicopter, it's the media. Any case the media puts on, you can be fairly sure the patient wasn't actually envenomed. And the afternoon here, North Shore Hospital got one of the most severe red-bellied black snake bites I've ever treated, but no one knew about it at all because they just brought themselves into hospital, or it was just a normal ambulance call for the bite. And finally, to finish with a nets one, and as a toxicologist, we have lots of involvement with nets. Nets calls us all the time, probably more than sometimes we want, and sometimes we're on the phone for like hours. But I think we've probably stopped half their retrievals and kept patients there. But however, the adult service, we rarely get calls. And the one thing I want you to go away with today is please call the Poison Centre and call them early and get advice, because we look after really rare and unusual things, and things that you will do differently to trauma or to other things like that. And you won't necessarily have to do particular things. And that's where the point is between helicopter and road. Often you'll find road would be much more useful unless they're in the bush somewhere. But How many snake bites actually occur in bushwalkers and in difficult places to get to? Very, very few. Most of them are on, to be honest, rural properties or somewhere where it's easy to get to. So this is a Nets call. So a 2-year-old boy walking from the garage to grandparents' house said he was bitten by a snake. He collapsed. We don't know, but assumed he had a cardiac arrest. His father gave him CPR. He was unconscious for 30 minutes. He was transferred to Orange Base Hospital. In hospital, he was awake, hemodynamically stable, but he had a severe coagulopathy, and he was given 1 vial of brown snake. So the one thing about brown snake is you will usually have a completely asymptomatic patient, and often even if they've had a cardiac arrest or a collapse, you may see them after that and they may be completely asymptomatic. And certainly the first brown snake I ever managed at the end of the bed in Darwin was exactly that, completely well patient. Then we used to do whole blood clotting times. And we were sitting there talking about, I said, I've come in now because I went to Darwin to see snakebite. I think this is about the 12th time I've come into hospital and another non-envenomed patient. Anyway, someone said to me, how long have you been holding that tube? Because that blood's not clotted. And sure enough, this Indigenous woman, she was completely well. And I went over and I said, husband said, when I was driving her in, because they'd driven in from Adelaide River or something, he said, she went to sleep in the back of the car for about half an hour and then she woke up again. So it actually had a collapse then and then she was completely well. So this is for brown snake, it's the most important thing. I'll talk a bit more about collapse as we go. So Nets called. They said, we're going to retrieve this patient back to Sydney to one of the intensive care units. I can't remember which one it was. So was there sufficient antivenom? Because this is about 8 years ago. I've got need for transfer to PICU, but they were basically saying, we're about to transfer this patient to PICU. And are there any other risks of further cardiovascular effects? My advice was, the father saved this child's life, done and dusted. He's had sufficient antivenom. And the only thing, as it's a brown snake, almost all, not all, but a lot more collapses are in brown snakes. And it's mainly what we see in New South Wales. Coagulopathy will recover in 12 to 24 hours. There's no risk of severe neurotoxicity. And there's no reason to put this patient in intensive care because they're not going to be intubated and ventilated. They've just got a coagulopathy. All you're going to do, the only reason you're keeping this patient, this child, or adults in hospital is it so they don't trip over and hit their head or cut themselves or something. All you want to do is stop bleeding complications. So went to the paediatric ward in Orange, didn't need any retrieval at all. Yeah.
Only the lack of neurosigns that made you confident to give just the monovalent there?
These days, we'll give brown and tiger anyway to make sure that we've covered that. It's mainly the collapse. Collapse is a lot more common in brown snake, plus the lack of neurosigns in the patient. And we almost see, like, New South Wales almost has no tiger snake bites, made sometimes in Canberra and south, but in the north, we've wiped them out. Tiger snakes get wiped out by humans in terms of building stuff, unlike brown snakes, which it does the opposite. They don't mind it. Yeah. Any tiger type bites in the north are actually rough scales, clinically the same. But yeah, the 1 vial here, if this was like now, we would have given 1 brown, 1 tiger. Because we don't know, and then we know we've covered it. So he's admitted, fine, no issues at all. He had a transient thrombocytopenia, occasional red cell fragment. Is just charged with that sequelae. I'm not actually going to talk about thrombotic microangiopathy at all, but that's a mild form of it we see in brown snake, just because it's more of a complication in hospital than anything that affects early care of the patient. So the Australian Snakebite Project, we started back in about 2003. This is a publication of the first 10 years of that. It continues today in various different forms in terms of, because a lot of it relies on us being told by cases from the emergency departments, from the poison centre, and so it varies across states. The important things that this study showed, one was controversy about dose, and I'm going to talk a little bit about that. The other was that timing was often ignored in terms of antivenom. But probably the biggest thing was about deaths from snakebite in this, how they occur, and what's the best treatment for them. I'm going to talk a bit about that briefly here. So that's the number of snake bites there, the number of envenomed cases and deaths. So the death rate is 2.3%. The Australian Snakebite Project probably gets, at this point, about 80% of cases in Australia. It's really hard to know, but when we were searching those, and we'd even searched media reports, there was very few that we missed. And to be honest, the ones we missed were bigger hospitals who felt they knew how to manage snakebite, and they wouldn't call unless we'd made relationship with them. But often it's unusual. Hospitals would see, probably the hospital in Australia that sees more snakebite than any other is Lismore-based hospital. And I don't really know why. It's not Cairns, it's not Darwin, it's not Nambour, ones that have always said that. But yeah, we've got lots of cases from Lismore. So yes, deaths, quite a high death rate, but that's of envenomed patients. And there's lots and lots of stick bites and non-envenomed cases in Australia, but there's actually very few get antivenom. And we've never had more than 100 uses of antivenom in a year to the Australian Snakebite Project. So even if we're only getting half the cases, you're still only talking about twice that. So it's a rare thing that any single doctor is only going to see very uncommonly in their career. And so therefore, one of my other messages will always be, and it's mainly to doctors, is to call a friend if you haven't seen it before. So most of those early deaths are cardiac arrests, and they all occur within an hour. And we've looked at this. It's not quite published yet, but hopefully it'll be published in the next couple of months. It's been presented. So this is more recent. So I haven't got the dates there, but it's from 2005 right through to about 2020, I think the data's from. 157 cases with collapse. A quarter of those had a cardiac arrest. Like 30% had a seizure, but a lot of them didn't have a cardiac arrest, as you'll see on the next slide, and 14% died. 21 immediately post-cardiac arrest. The other three had intracranial hemorrhages, and one had severe myotoxicity. That graph's wrong because it's been fixed, but all cases occurred within 2 hours, and only two occurred right out there, and they both had really tight bandages on, and then happened after the bandage was taken off. Almost all cases occurred within 60 minutes, and a number occurred pre-hospital. So yeah, this gives you the numbers better. So of that 157, a bit over half just have a transient hypertension. Well, we call it hypertensive collapse, but we can't really call that because they're transient collapses in patients that no one measures the blood pressure on. So we assume that in some of the patients where it's been done in hospital, but they're unresponsive. Often they'll breathe, and often when they're in hospital, they often wake up before someone even gets around to doing much, like even adrenaline's not drawn up. So that's quite rapid response if they don't go into cardiac arrest or have a hypoxic seizure, which is that smaller number. And then those are the ones that die. So in terms of death versus survival, we've got the pressure bandage information there. It looks good, but as I'll talk later, I'm not convinced pressure bandages do all that much unless they're put on like tourniquets, and then they tend to cause harm rather than a benefit. So only a third had a pressure bandage in those that died, whereas most that was applied in the survivors. But the more important thing is you can see that those that survived got immediate CPR, whether that was in hospital or by a bystander or by ambulance who'd actually arrived on the scene by the time of collapse, versus those that died. And there's been some very unfortunate deaths in Sydney. There's been quite a few kids that have collapsed and no one's done anything at all. And then they've died basically from that collapse. Whereas this is very reversible. They only have to get CPR for 5-10 minutes, and then they'll get return of circulation, and then they're fine after that. Anyone who's got early intervention, I shouldn't say anyone, there's been 1 or 2 cases where they haven't survived despite good hospital care. But on the whole, they'll survive. So from that same information in the Australian Snakebite Project, this is just in terms of the types of snakes. So that makes up most of the snakebite in Australia. So brown snake by far the most, simply because they occur everyone that we're on the mainland, and there's just more people where they are. Next most common is actually red-bellied black snake, but it's just because everyone's there. But if we put, you'll see tiger snake, I haven't marked rough scales under that. Clinically, they're essentially the same. Taxonomically, they're very similar snakes. So you can really just put the two together. And you're never going to tell the difference unless someone's actually seen the snake and identified it. So the tiger snake group is the second most important one, followed by red-bellied black snake. And then after that, everything's rare. Why I point that out is because you can treat those 4 top snakes with a vial of brown and a vial of tiger. And we don't need to work out what type of snake it is. We don't need to focus on it. I haven't actually shown the data, but in that same study, we showed that the venom detection kit is, I wouldn't say absolutely useless, but all it does is create confusion and it is wrong. So it's often done in non-envenomed patients, and we get non-envenomed patients being given anti-venom because the kit says it's brown snake, even if there's nothing there at all because of a false positive. So it's done incorrectly by clinicians to start with, despite 30 years of education. Even if you take that out and you take the ones where it was done in envenomed patients, a sixth of them, the result is either wrong or negative. And so when we looked at it in Victoria, the thing about Victoria is they almost have no brown snake bite. I don't know why. There's lots of brown snakes there, but almost every bite in Victoria is a tiger snake bite. And in our study of tiger snake, we had 3 cases that were positive for brown snake, because the kit is more likely to give you a false positive for brown snake. All those patients to this day thought they were bitten and envenomed by brown snakes, treated by brown snake antivenom, but because we do our own venom detection in blood, all 3 were tiger snake bites. So the kit is not going to be helpful. And as long as we give 1 brown and 1 tiger, you will treat 90% of bites in most cases. It then does leave us the taipan, mulga, death adder, which are uncommon. Half of those occur in snake handlers. So they're snakes that are in captive. So it's really a very small number. And those we would just give polyvalent to. So, and that's why, as I said to you, we keep polyvalent in strategic places in the hunter. And when I think the New South Wales Snake and Spider Guidelines finally get out, which I think's very soon, we say to each area health service, look at your service and where would you want to keep polyvalent, and things like discuss it with your retrieval service, or where do you put it so you can get it somewhere quickly, or is it in in big hospitals? So it simplifies what we do is that we don't necessarily want to know about the snake. We've got a patient who's got a coagulopathy and a snake bite, we just give him brown and tiger. And and I know simple might seem to be dumb, but no, simple's smart here. Okay. And this is coming back more to the point, is that often when I've given talks about critical care and first aid, this goes also for toxicology as well. This is what is the most important thing. We get called all the time in Poison Centre about some patient and what antidote should we give? And we always just go back, okay, so how is their airway and their breathing and their circulation? Because that's good for 95% of your toxicology patients. I'm on one extreme. I'm often called Dr. TN, therapeutic nihilist, versus some toxicologists who love antidotes. But I would say it's supportive care that's good. Go back and do it, and you do best is when patients will survive. Same with snakebite. As I said, it's CPR. What's the best first aid for snakebite? It's CPR, then immobilisation, then the pressure bandage. Actually, the one that I haven't put there is actually mobile phone is probably the most important one, because you often don't have the pressure bandage and immobilisation there. Prevention, like most people won't get bitten by snakes if you're wearing appropriate clothing. They can't bite through, they've got small fangs, they can't bite through jeans, can't bite through boots. So most occur, as we say, in men, 75% of bites occur in the upper limbs, and in women, 75% of the bites occur on the lower limbs. They say it's a lot about alcohol, but to be honest, stupidity over alcohol in most cases. Okay, so there's a lot of controversy about dose, and for those who've been around long enough will know that at one point when I was a registrar, doses were just escalating. The West Australians were giving 10 vials of brown snake. In New South Wales, we were giving 4 or 5, and I'll show you why that is. And there's still controversy. Even when we say 1, there's still people in Australia who think that it's clinically criminal that we do this. And as I said, timing is often ignored. So I want to talk a lot about timing. So yeah, after we published that study, there was editorials, I think, in every critical care journal in Australia. And EMA had one, anaesthetics in intensive care, and even in the MJA about how the correct, do we know the correct dose? It's interesting that all these people there have actually done no research, and there's nothing scientific based on what's here. It's all based on history, of which there's no science. Well, in fact, if we go back to where the science was, Commonwealth Serum Laboratories was one of the greatest scientific institutions we've had in Australia. And what dose did they recommend of all the antivenom? 1 vial. It wasn't them who changed it. It was a bunch of clinicians who changed it. So in terms of looking at evidence-based, a lot of this is based on eminent opinion of people who've seen lots of cases. So this is just brown snake because it was always the most controversial. Clearly, we can't do RCTs or systematic reviews of antivenom against a placebo, although actually we have done it for red-bellied black snake because it wasn't necessarily a standard of care to give it, but certainly we couldn't do it with brown snake. But in a prospective cohort study, we showed that 1 vial was effective, and there was no difference in the number of vials that were given. And we did antivenom before and after. I want to talk less about that. I want to talk more about, recent current practice. It's getting less and less current. This is 20 years ago. So there's increasing doses of antivenom. So antivenom needed to be titrated to coags. And if the coags were abnormal, then you kept giving more antivenom until the coags normalised. And so what you ended up with was the total antivenom dose was 14 divided by the frequency of the coag tests. The 14 is the median time for the coagulopathy to improve, which is actually just how long your liver takes to get your INR from unrecordable to under 2. So if you could do, and in some cases, the record's 9 coag tests within 14 hours, then that's how many vials of antivenom they will get. So I love this case. So those green spots there are antivenom being given. This was a tiger snake bite in Victoria, and that's how often they did coag tests. So every time they did a coag test, they gave another vial of antivenom. So they gave 8 vials. This patient still had myotoxicity with a CK peak of almost 9,000, and they had neurotoxicity. So it really didn't stop the things that we want to stop in a tiger snake bite, yet they got lots of antivenom. And as I said before, their CSL's original recommendations, in fact, brown snake, they just doubled the dose back in the 70s because everyone was giving more larger doses. So they said, we'll just double the dose that's in it because it was the smallest one. So really, at some point, the West Australians who were giving 20 vials in a brown snake bite were actually giving 40 times the original dose. And it was based on a laboratory study that was done by a clinician in Western Australia. And based on that, we had this huge increase in doses. Interestingly, where did the dose increases occur? It only occurred in snakes in which VIC occurred, so venom-induced consumption coagulopathy. It's never changed for mulga. It's never changed for death adder because you can't do a blood test. Sometimes more is given because neurotoxicity doesn't get better, but at least there's less controversy over neurotoxicity in Australian snakes is presynaptic, so it's essentially irreversible. It's not going to reverse by giving antivenom. It will improve over time, but we knew it was that, so people would know that as long as you're given a dose, you don't need to give any more. So, as I said, we escalated the doses over that period of time. And the West Australians reported this over 10 years. The problem with this study was essentially all they reported was what they were doing and then said, okay, well, then we should continue to do that. They didn't actually examine what they were doing in terms of what was there an issue with it. So WA stocked every hospital with 10 vials of brown. And that year, for 3 months, there was a shortage of brown snake antivenom. Although CSL, and it was CSL then, promised that wasn't because of that, I find it very hard to believe when one state buys a few thousand vials of brown snake antivenom that we can't get it from anywhere else. So coming back to this case, because the most important thing that was missed here, sorry, can anyone say, does anyone see why in this case they still developed toxicity despite getting so much antivenom? Yeah, as you can see, the first dose is almost at 6 hours. And so the problem is we want to give it as early as possible, but then often the measure you've got for the patient getting better doesn't work. So this just shows here that so the PD is the pharmacodynamics of anything, which is the effect. PK is the venom. And as you can see, the first dose of antivenom, and this is a different case, is that arrow. So the venom concentration was just above 5. It goes to 0 as soon as antivenom is given, but the coagulopathy doesn't get better. And we can't measure that anywhere. We just have to, doing prospective studies, show that that's sufficient. So this is the issue. That's why this patient got those effects. And going back to the case record, the patient had nausea and abdominal pain 15 minutes post-bite. So what about the timing of antivenom? So, and the reason for this is what we want to know is when antivenom gets into the circulation, and as soon as it's there, that's when antivenom is going to work best, because you're going to put intravenous antivenom to meet venom in the circulation. So one reason that's an IM antivenom should never be used for anything at all. I know it's still used for box jellyfish, but it's not going to work. It's not going to get there. And we need it in the central compartment. Unfortunately, the effects happen once it gets back out to its target organ. So that's what makes it most difficult. So the critical time for envenomation diagnosis is when it's in blood. We say it goes in by the lymphatics. That's true, but there's now rat research to show that it goes in probably by precapillaries as well. So it's almost like IV. And certainly if patients are collapsing in 5 and 10 minutes post brown snake bite, then it's come much quicker than the lymphatics. So we know it's there early as possible. So I'm looking at this PK/PD biomarker mismatch is actually even easier to see and in myotoxicity. And what I want to show it here is you're never going to prevent coagulopathy because it really does occur within 1 hour and no one's going to get antivenom within that period of time. Myotoxicity takes longer to develop. Venom's got to get back out to the muscles and that takes hours. The problem is the biomarker we have is CK. So essentially, and then that muscle injury is hypothetical because we don't really know where it's occurring. We know where venom is because it's measured and it's gone within 24 hours. The CK goes up for hours, days later. And really, if the CK goes up, that biomarker simply tells you that you didn't give antivenom in time. And there's muscle injury. It's this idea that you can titrate to CK, or even I know we get serial CKs done, but to be honest, it's only going to tell you that, there's muscle injury there. It's not going to help you with antivenom. So this is our biggest problem, is that we cannot, it's deciding whether a patient's envenomed early enough so that we can give antivenom. And we've certainly got evidence for this. So certainly in red-bellied black snake. So this is a combination of the RCT data that's not published and prospective. This is one of the most difficult RCTs to ever do, because you've got to put them in every single hospital that's got these. We've got a lot more prospective data. And as you can see, that's the rate of myotoxicity. So except for 2 early cases who got, one was a CK of just over 1,000, so they met the criteria. And the other's a 16-year-old who is the most severe envenomation we've seen in black snake, where 1 vial wasn't actually enough for red-bellied black snake. And the reason for that is that the biggest problem with red-bellied black snake is we use tiger snake. And why do we do that? No one can tell me. It's historical. And it's not because there's cross-neutralisation between tiger and black snake. It's simply that all of our antivenoms are polyvalent. So that's what I'm saying. So we have polyvalent. To be honest, polyvalent will treat 40 brown snakes. It's got 40 doses of brown snake in it because it's got every single one added up. CSL or Seqirus now, they only have 1 bunch of horses, and they all get injected by all 5 antivenoms. And when they bleed them, you're getting polyvalent. The only reason they put it in brown snake is they can guarantee that in brown snake there's 1,000 units. And in tiger snake, there's 3,000, and that you can treat one bite is 1 average yield from a snake. So the more the snake delivers, so the reason black snake or mulga, the one we use, is 18,000 units, is because a mulga snake delivers 180 milligrams of venom just when you milk them. So the problem is what the polyvalency is about how much is there. So if you want to treat a black snake, you want to make sure you've got enough black snake there, but you need larger volumes to do that. So brown and tiger will cover those because they're both small. And if they made a low volume polyvalent, that'd be great. And in fact, that's what vets have. You'll see that it's 44,000 units, covers brown and tiger. It's what we do by giving 2. They've got it 1. Won't happen because it'll cost Seqirus, $250,000 to register it as a new product, and they probably won't be even able to register it because it doesn't meet all the requirements. So that's probably why these cases didn't. But you can see that you've got 6 hours to give antivenom for red-bellied black snake. Unfortunately for mulga, it's probably only about 3 hours, and for taipan versus neurotoxicity and preventing intubation, it's probably still only about 2 to 4 hours. So really, that's our as I'll call later, a golden hour is within that brief time. The problem is, over the whole period of ASP, the median time to us giving patients antivenom hasn't changed at all. We haven't improved that at all. Again, this is actually, I only just will be presenting this in a couple of months. So patients get to hospital in time. They're there in 60 minutes on a median time. So they're all there in time to get it. When do they get antivenom? Median time, 4 hours. So there's a 3-hour delay, and that's not to do with the patient. That's not to do with being in hospital. As it's mainly to do with bloods. As you can see, first bloods at 90 minutes. Takes an hour to do them, or no one chases them up. And unfortunately, Poison Centre gets called with the blood tests, whereas we want to be called when the patient arrives. And you'll see that if you look at therapeutic guidelines or any new guidelines, the pathway goes, do they have symptoms? And if they do, you need to think about antivenom and call a poison centre. So at least you can blame someone else if they're not envenomed and they have an allergic reaction. You can say, well, that's what the poison centre said. And I've given a lot more antivenom to non-envenomed patients in the last 5 to 10 years. Same as I say with appendicitis. Any surgeon who says that they haven't taken out a non-inflamed appendix, they're missing some because you're never going to get it quite right. We'd prefer to treat them. So yes, but of the hospital transfer data, so of that, 30% of patients are retrieved right across ASP. But this is a second, so this is from one hospital to another. This isn't a primary retrieval. So median time was about, as you can see, is a bit over 4 hours for that. Time to antivenom was similar between the two patient groups. Most important thing is the median time in the patients who were given antivenom prior to retrieval was 2 hours, and you're retrieving them to get blood tests done. So this group are actually going, okay, I'm going to have to retrieve this patient. And, 4 hours is good. Sometimes it's 9 hours before they get to the next hospital. It's like, well, it's all too late. Don't even bother doing the blood test because we've needed to give antivenom. So these patients did better because the decision was made, do we give antivenom before we retrieve this patient? And it's yes. And as you can see, it's under 2 hours, whereas on average, patients get it at 4 hours. So how do we decide about early antivenom? And to be honest, there's no current tests. We can do one in the lab. We can measure phospholipase 2, and it's a great test, but it's not available at the bedside yet, and it's not available in labs. Until we have something like that, then we have to just go with clinical effects. So we've looked at that in patients. This shows the best ones are a headache and vomiting is the best, and at least 2 of these early symptoms. So that doesn't, people talk about dizziness and diaphoresis. The ones that are most important to me, vomiting and headache. If you get either of those, I will not dismiss those as anxiety, and I'll treat based on those. Nausea is harder, but often you'll get nausea and then you'll say, oh, they've been given an antiemetic in the ambulance. And I think, well, if you're giving an antiemetic for nausea, then I'll use that as well. Abdominal pain and diarrhea are great if they're there, but it's really only going to be a mulga snake. And a mulga snake, if you've ever seen one, is almost like an acute abdomen. They're that sick in terms of their systemic effects. So you won't miss it. So as vomiting and greater than 2 symptoms are the ones that I'd go for. So I like talking about the golden hours. We've got the golden hour for TPA. We've got it for antibiotics, for chemotherapy, for patients with febrile neutropenia. This is the problem with our 6 hours, is it's all too late. Non-specific symptoms occur early. This is when we get laboratory investigations. That's when they're done, but it's more about waiting for tests and results. And we know that many smaller labs that do coag tests, they're usually done in the evening when snake bites occur. It's not a coag scientist. And as soon as the machine says there's something wrong with it, they then start doing all sorts of other tests. And about 2 hours later, they go, oh, can you collect it? We had a great case at Tamworth where it was recollected 3 times before they call the ED consultant, who said, oh, you've given antivenom, haven't you? Oh, no, the lab still has. And it's like, well, if you get an abnormal coag test from the lab, then you can almost give antivenom based on that. But just tell them. The other thing about it is the prothrombin time is 12 seconds. So how long does it take to do the test manually? 12 seconds, or just set it up 10 minutes. It's the machine that says, oh no, there's something wrong, so we'll do this and we'll do that. So not that it's such an important pre-hospital thing, but yeah, blood tests can mess that about. So early signs, the decision can be complex, and when it's complex is what snakes occur where, and how do you get that information? You guys get it from the Poison Centre, and I will say that within the Poison Centre, we will escalate that. So I will get about 1/3 of the snakebite calls on top of that. So the clinical toxicologist will call me and say, for whatever reason, or do we know those snakes are there? Can we ID it? We do it for all toxicology. So if it's organophosphates, I'll call the 2 toxicologists who've done a whole lot of work in Sri Lanka on organophosphates because they know about it. And then you always get the best advice that there is. Call a friend. I'm in an emergency position, and I always made sure I called someone else so I could blame them for the decision that was being made. Call the cardiologist. They got chest pain. Cardiologist said the patient can go home. I mean, it doesn't mean do stupid things if they're making stupid decisions, but why not get that advice so that the patient gets the best care? So the new approach now is to decide early. We give polyvalent, i.e. brown plus tiger, or polyvalent, and there's no evidence for redosing. The biggest problem with the hospital is that it needs to have a lab that can do an INR. That's the main reason you're retrieving patients from one hospital to another. It's not to give antivenom, and it's very rarely for an intensive care unit. So pressure bandage, because people, with the Darwin case, I'm not sure whether you've actually seen it. So part of that was that the patient had a tight bandage on, which they had to release a bit, and then the patient seemed to get more unwell, and they gave antivenom for that. Pressure bandaging, there's no evidence that it works. So the study was in 1979. This was restrained monkeys. So these were monkeys that were restrained in a seat anyway, so they couldn't move. And then they had a bandage put on, and then they did an old venom test to show it. So that's all that we have for evidence. I don't believe it works properly unless it's really put on correctly. And I'm not even convinced if you put it on at the tightness for lymphatics, it's going to work. There's some, people say, oh, it worked in this case, but usually it's put on as a tourniquet. We know that tourniquet works because it stops everything. And that's fine if you can manage a tourniquet, but it's not fine if it's left on for 6 hours. And so these two cases were published by Mark Little in the Cairns area, where they had both had quite significant complications from having a bandage on too tight. So they got CKs up, and they had compartment syndrome from it. So it can cause injury, and often ambulance is giving pain relief. And the reason they're giving pain relief is for the pressure bandage, because Australian snakebite really doesn't hurt, particularly not early on. And this is the sort of thing you see. The problem is who's going to loosen that bandage that's on already? That's our biggest. Once the bandage is on, then we're in this dilemma of, can we take it off? It's easier in hospital because we've got antivenom, but in flight or in an ambulance, that's a much more difficult decision to make. And it's reasonable to give a pain relief. You're not going to cause these sort of injuries as long as everyone's aware what your timing is. And if you are out at 6 hours or something, then yes, we need to make an educated decision about loosening that bandage and whether it's worked. Ultimately, most people don't get it on, and that's what we showed in this study. Even when you taught them, the only thing we showed was that if you trained the snake handlers, they got better at it. If you trained everyone else, and so this included the general public, ambulance officers, medical staff, you really weren't much good at doing it. So I don't think it works ever. Why do I advise it? Because if we stop doing it, people are going to start doing really dumb stuff like cutting it, sucking it. So that's why, even though those two cases were published and we can cause harm, I think we still cause less harm by having something that people can do. And then certainly in this study there, we really showed there was no consistent association between the use of bandages and the complications in snakebite. So I'm almost finished, and I've going to go a bit over time. One question was about treating coagulopathy, FFP and snakebite coagulopathy. So this is one of the randomised controlled trials we did. And so we showed in a randomised controlled trial, so that all patients got antivenom, and then half were randomised to either FFP or no FFP within 4 hours, and the outcome was an INR. And we definitely showed that if you gave FFP, they had an INR less than 2. So it worked for that, but if that's your outcome, that's good. Really, the outcome is hemorrhage. We didn't even show any difference to length of stay. So, and it's going to get better in patients. It does take 12 to 24 hours, and you're better to wait.
Let's just question about patients. Sorry.
Any issues with patients on anticoagulants already? I appreciate these are usually young patients not on them, but anyone on DOACs or warfarin, would you have any other?
Oh, they're just painful to diagnose because you've got a patient who's got an abnormal INR, who normally has an abnormal INR in a snake bite. This is where D-dimer and fibrinogen are quite good because you're looking for a VIC. I don't think the treatment's any different. It's more the diagnosis is the problem, and you'll get things being done because of the warfarin. So it's the interpretation of the coag so much. My advice is the one thing we showed in the study is there's some non-responders. If you give FFP too early, there still seems to be this time where there's consumption going on despite antivenom. And I won't go into the reason, but we could show it between these patients. It's time from bite, not time from antivenom. So in actively bleeding patients, yes, we would give FFP, but try and wait till at least 6 hours after the bite, because all of these non-responders got early FFP. and there seems to be, and you seem to be putting fuel on the fire, not because of not because the venom's still there. It's actually to do with the whole coagulation pathway still being ready to go again. Yes, I'm not going to talk so much about the reasons for that, the early being a problem, but yes, early is problematic with FFP. So yes, it's certainly not something you want to use, pre-hospital. And yeah, just reiterating what I've said previously. So feel free to call for advice, discuss cases. The earlier, the better, and also to think about how where you can get antivenom. So if you're going to do a primary retrieval, then it is worth thinking about antivenom and giving it on site. I mean, it's a lesser intervention than a lot of things that you guys already do on site, and all you simply got to take it and treat anaphylaxis. But you've got to plan it beforehand. You can't say, oh, where is it? Oh, where you don't want to be trying to find where it is. You want to have a plan. Oh, we're going to go to this hospital to pick it up, or we're going to have it here. It needs to be kept cold, so that becomes a problem at keeping it. And that was really what Newcastle's problem was, is having packs so that they could keep it that cold. Yes, so in terms of this, road may be best sometimes, and sometimes you can make a decision not to take a helicopter unless you need the helicopter to actually get the patient. It's different. But yeah, don't use helicopters to take patients long distances after envenoming. You better to work out the best way to take them a short distance. Call antivenom. There's a third version of therapeutic guidelines. If you want the most up-to-date national advice on anything toxicology, to be honest, therapeutic guidelines are certainly SnakeBite, rather than other ones that are available. Thanks. And that doesn't even list all the ASP investigators, but to be honest, there's hundreds of lab, ED, pre-hospital, and poison centre people that have helped the study over the last 20 years.
Geoff, just a quick question on what about an asymptomatic patient? Would say a very remote asymptomatic patient after a potential bite who has a long transport time ahead of them, would the transport time influence your advice on whether to give antivenom or not?
Not in an asymptomatic patient. So
it's just if you're not relying too much on the pressure bandage mobilization to actually prevent the envenomation developing, then you might run into a situation where they develop symptoms and signs during transport. If
you're going to get the symptoms and signs, it's going to be within an hour. So our biggest problem, or not problem, is that brown snake bites are asymptomatic. The thing about that is the antivenom, I don't believe, and we do have evidence, that the antivenom, you'll never stop that coagulopathy with antivenom. You don't give it to patients, it won't do anything. We can't not do that. But what it means is I wouldn't give it there. It's mainly tiger snakes and black snakes where we know antivenom is going to prevent myotoxicity or neurotoxicity. So make the decision early. But like Queensland, not so much New South Wales, or I haven't been involved, often you get a hospital that'll ring and say, I've got an asymptomatic patient, I can't get labs, or it's going to take 24 hours to get labs back. I'm going to have to retrieve this patient. It's the middle of the night. The weather's bad. Is it worth doing this? Often just leave the patient there if they're asymptomatic, because in no way are you going to give this patient antivenom within 3 hours. So why fly them somewhere else to either get abnormal labs to say, oh, we should have given antivenom, or not to do anything. So recently I've done that in Queensland, and often I'll say, send off your lab tests, and I know you're not going to get them back. All we want to do is to see whether they're envenomed or not. This is not really about antivenom. But that's where you want to ring me so that if anything happens, you can say, well, that's what Geoff told me. So we did that.
That means I might have missed something. So whether or not it develops is a different question to whether or not because it's ultimately reversed quicker with antivenom.
Oh, it's never reversed quicker. Yeah, so the study we did basically showed, we looked at the time of antivenom given and the recovery of Vic. And it recovered exactly the same. It didn't matter when you gave antivenom.
Yeah, but you gave it. So if you didn't give it, does it?
Oh, I don't think it does, but we couldn't not give it. Yeah.
Okay.
But what we did do is in that so that was prospective. It wasn't RCT. We did have some patients who were given FFP, and you can clearly show that the earlier you gave FFP, the earlier the patient recovered from Vic, because you're giving them factors, whereas antivenom made no difference, nor the dose. But no one's going to stop giving it. We haven't really shown that it doesn't stop thrombotic microangiopathy and acute kidney injury, but I really don't think it does much in brown snake.
In other causes of cardiac arrest, CPR doesn't usually bring them back without fixing the underlying cause. What's the proposed mechanism for the arrest in brown snake envenoming?
It's a release of secondary mediators, so it's probably closest to anaphylaxis. So what seems to happen is, and we've shown it in rats, is that the venom causes a release of all sorts of vasodilatory or vasoplegic substances, and so you get hypertensive. Heart's probably fine, and all you're doing is you're waiting for that to get better. So yes, there's no ongoing damage, and that's why, as long as you can get through that brief period.
Huge thanks for the talk. It's great to get an update and make sure that we're still on the same page. For retrieval services, we all used to carry anti-venom, like we would have it in the base, and it would always go out of date because the ambulance services kind of learned that sending a helicopter is not really the answer for these patients, and that was the exciting thing to send. But now just bringing them by standard ambulance to the nearest hospital is a much better system, and only retrieving a very small number who need ongoing treatment. But we can access antivenom if anyone's interested. The Aeromedical Control Centre keeps a record of where they are and can supply us with them and avoids all that cold chain problem of storing it on base. And it's still very uncommon. We get sent to people in the bush who might have been bitten, but very, very rarely do they actually have an actual envenomation. So it's an interesting but rare area. It always makes our UK colleagues who come to work for us very anxious. But I'm glad that you can reassure them that it's pretty straightforward. We give you guys a call early on and make sure Aeromedical Control Centre knows about the case.
Yeah, I think that's the key from our point of view, probably, isn't it? It's that there is at that point of tasking, if we are tasked to someone with a snake bite and a symptom, then we call these guys at that point of tasking.